Hi rabbits, Research Turtle here. Today we are exploring a new horizon in CVRM, that is, cardio-renal metabolic management. We're moving beyond simple blood sugar control to look at the powerful synergy between two giants, empagliflozin and metformin. From molecular mechanisms to the latest 2025 guideline updates, let's dive into why this is the new standard for organ protection. Let's start with the big picture. We're witnessing a fundamental paradigm shift. The old view was glucocentric. We treated to failure. We used a stepwise approach, only adding a new drug when the previous one failed. The result? We were often too late, reacting to established damage. The new CVRM view is proactive preservation. The primary goal isn't just lowering HbA1c, it is preventing the collapse of the heart and kidneys. The strategy is early combination therapy. By hitting multiple pathways at once, we address inflammation and fibrosis before they become irreversible. Now, let's look under the hood at the molecular level. This is where the synergy gets fascinating. When empagliflozin inhibits SGLT2, we excrete about 70 to 80 grams of glucose a day. This is great, but the body perceives this as an energy deficit. In response, the liver paradoxically increases its own glucose production by about 31%. This is where metformin comes in as the perfect partner. Metformin activates AMPK and specifically blocks this hepatic glucose production. Think of it as a lock and key mechanism. Metformin neutralizes the spike caused by empagliflozin, maximizing the net blood sugar lowering effect. The synergy extends deep into the cell. Empagliflozin acts as a metabolic switch. It shifts the body's fuel source from glucose to ketones, specifically Beta-hydroxybutyrate. This is a super fuel that improves ATP efficiency in the heart and kidneys. Simultaneously, metformin acts as an anti-aging agent. By inhibiting mTOR, it promotes autophagy, essentially cleaning out damaged organelles and reducing cellular debris. Together, they reduce oxidative stress and inflammation, providing a double layer of cellular protection. When it comes to the kidneys, we're building a dual defense line. Empagliflozin provides hemodynamic control. By restoring tubuloglomerular feedback, it reduces the pressure inside the glomerulus, stopping hyperfiltration. Metformin provides structural integrity. Recent data shows it inhibits TGF-beta1, a key factor in tissue scarring. So, while empagliflozin relieves the pressure, metformin prevents the fibrosis. It's a complete package for renal survival. We all know the landmark EMPA-REG outcome study proved empagliflozin reduces cardiovascular death, but a common question is, does baseline metformin change this benefit? The answer is a clear no. As you can see from the interaction analysis, the hazard ratios are consistent. Whether the patient is on metformin or not, empagliflozin delivers its cardioprotective benefits. The effect is additive and robust, even in high-risk groups like those with prior bypass surgery. For heart failure, this combination optimizes both hemodynamics and bioenergetics. Empagliflozin acts like a smart diuretic, reducing volume overload without activating the sympathetic nervous system. It also promotes reverse remodeling, actually shrinking the left ventricle. When combined with metformin's energy efficiency, we see potential improvements in functional capacity. This aligns with findings from the Emperor-reduced and preserved trials, showing a 25 to 30% reduction in hospitalization risks. Let's look at the long-term kidney function, represented by the eGFR slope. Notice the initial dip in the green line. That is the hemodynamic effect of empagliflozin relieving pressure. It's reversible and expected. Following that dip, the decline stabilizes significantly compared to the placebo. New evidence from the MET-EMPA-CKD study reinforces this. It shows that empagliflozin targets tubular injury markers like KIM1, while metformin targets fibrosis markers. They're protecting the kidney through distinct complementary pathways. Clinically, we also care about the numbers the patient sees. This combination delivers a double hit. You get superior HbA1c reduction, up to 2% in high baseline patients. But look at the weight. Empagliflozin burns calories via urine, targeting visceral fat. Metformin helps regulate appetite. Together, they achieve significantly greater weight loss than metformin alone, along with a synergistic drop in systolic blood pressure. So, how does this change our practice? The 2025 ADA and KDA guidelines have solidified the era of early combination. The old stepwise approach is reactive and slow. The new standard dictates that if a patient has comorbidities like ASCVD, heart failure, or CKD, you do not wait. You start an SGLT2 inhibitor immediately, often alongside metformin. If the HbA1c is high at diagnosis, we initiate combination therapy from day one. We're no longer treating failure, we're proactively managing risk. With great power comes the need for responsibility. We must educate our patients on the sick day rules. Because of the risk of dehydration and the rare double hit of lactic acidosis and euglycemic DKA, patients must stop both medications during acute illness or before surgery. Also, remember the renal rules. While empagliflozin can be used at lower eGFRs, metformin is contraindicated below 30. When using the combination, always follow the stricter limit. To wrap up the clinical application, don't be afraid of the sicker patient paradox. Older patients with lower kidney function often see the greatest absolute risk reduction. Utilize fixed-dose combinations, FDCs, to improve adherence and administer them after meals to reduce metformin's GI side effects. And remember, when you see that initial dip in eGFR, do not discontinue. It means the drug is working to relieve glomerular pressure. In conclusion, the empagliflozin and metformin combination stands on 3 pillars. 1. Metabolic efficiency, balancing glucose production and weight. 2. Organ protection, offering a dual defense against pressure and fibrosis. And 3. Mortality reduction, with proven survival benefits. We must move from treating failure to preserving function. This partnership is the cornerstone of modern CVRM defense. That's it for today. Turtle out.